Welcome. This is our presentation on placenta abruption by Matthew Ritter and Brian Rushing. The objectives for this presentation are to understand the placental abruption pathophysiology, recognize the initial presentation of placental abruption, review the diagnostic criteria, discuss the current treatment options, take a look at the perioperative management of placental abruption, review the anesthetic considerations, and then we will look at a case study. So let's take a look at the pathophysiology. The definition of placental abruption is complete or partial separation of the placenta from the decidua bacillus before delivery of the fetus. Premature placental separation is caused by rupture of the maternal vessels in the decidua bacillus. There is a theory that superficial trophoblastic invasion of the spiral arteries leads to an ischemic placental disease state, which fosters persistent placental hypoxia leading to preeclampsia, fetal development restriction, and abruption. The loss of the surface area that facilitates exchange of oxygen and nutrients for the fetus leads to fetal compromise. The classic presentation is vaginal bleeding, uterine tenderness, and increased uterine activity. Symptoms aren't always present, though. Placental abruption can present as a concealed abruption, which vaginal bleeding may not be observed. This leads to a largely underestimated maternal hypovolemic state. Non-reassuring fetal heart rate patterns will be observed, such as bradycardia, late or variable decels, and loss of variability. And placental abruption is usually diagnosed by clinical presentation. Some of the potential complications of placental abruption are hemorrhagic shock, coagulopathy, and fetal compromise or demise. 1/3 of coagulopathies in pregnancy are related to abruption, and coagulopathy is usually associated with fetal demise. Thromboplastic substances are released into the central circulation, and this leads to consumptive coagulopathy, which leads to DIC. Conditions that are associated with placental abruption are advanced maternal age, multiparity, preeclampsia, premature rupture of membranes, and chorioamnionitis. Maternal comorbidities are hypertension, acute or chronic respiratory illnesses, substance abuse, specifically maternal cocaine use, maternal or fraternal tobacco use, and trauma. So it's important to keep these associated factors in mind when managing these patients. So for the anesthetic considerations, the ultimate remedy is delivery of the infant and placenta, although the timing and mode of delivery are determined by the degree of maternal and fetal impairment and estimated gestational age. If the fetus is at or near term and both maternal and fetal status are reassuring, vaginal delivery may be appropriate. If the mother develops hemodynamic instability or coagulopathy, or the fetal status becomes non-reassuring, urgent cesarean delivery may become necessary. If intrauterine fetal demise is noted, vaginal delivery is preferred. Some considerations for management is the immediate access to a medical center with 24-hour obstetric and anesthesia coverage and a neonatal ICU. Some assessment considerations are airway examination, intravascular volume assessment, previous history of cesarean delivery or other procedures that leave a uterine scar. There should be availability of cross-matched blood and coagulation factors. 2 large bore IVs, aggressive volume resuscitation, invasive monitoring, fluid warmer, H&H, coagulation status, and a Foley catheter all are appropriate. Corticosteroids may be indicated to promote fetal lung maturity as well. These patients are at high risk for postpartum hemorrhage from uterine atony and coagulopathy, so oxytocin should be administered as soon as possible after birth. Replacement of red blood cells and coagulation factors should be done as indicated by lab results. To reduce the risk of developing coagulopathy, aggressive monitoring and early replacement of coagulation factors, particularly fibrinogen, is indicated. So for vaginal delivery, if hypovolemia has been addressed and the coagulation status is normal, neuraxial labor analgesia may be used in the case of abruption. There is high-risk postpartum hemorrhage due to uterine atony and coagulopathy. Prompt infusion of oxytocin after delivery is indicated. For cesarean delivery, neuraxial anesthesia may be administered if volume status is adequate and the coagulation studies are normal. In most situations of emergent cesarean delivery accompanied by an unstable maternal condition, non-reassuring fetal heart rate pattern, or both, general anesthesia is chosen in that case. Low-dose propofol administration with ongoing hemorrhage. Induction agents for hemodynamically unstable patients. You could use ketamine 0.5 to 1 milligram per kilogram and etomidate 0.3 milligrams per kilogram.
From an anesthetic management point of view, there are several considerations you should keep in mind when caring for a parturient with a placental abruption. Since most abruptions occur in the last trimester of pregnancy, many of these patients are going to have a physical and physiologic changes which could make them a difficult intubation. The redundant friable tissues and external anatomy, such as a large chest and abdomen, will make laryngoscopy difficult. A glide scope or other video laryngoscope should be considered, along with ramping and putting the patient in proper sniffing position. Since these patients are also bleeding, hemodynamic instability is also a consideration. Hemorrhage will lead to hypotension and tachycardia, and many of these patients will have a decreased response to adrenergic agents. An arterial line should be considered to carefully monitor blood pressure. Lastly, the anesthesia provider has to remember that they are dealing with more than one patient. Any episodes of hypotension, hypoxemia, or hypoventilation will directly affect the baby and contribute to negative outcomes. Initially avoiding opioids upon induction will decrease fetal depression upon birth. As stated in the previous slide, many of these patients with a placental abruption will be hemodynamically unstable secondary to hemorrhage. In cases where the abruption is significant enough that the baby is not able to undergo a vaginal delivery, a C-section will be performed. Induction medications should be carefully chosen in order to maintain adequate blood pressure and fetal blood flow. Ketamine and etomidate are both excellent choices considering their hemodynamic profiles. Since parturients are considered full stomachs, a rapid sequence induction with succinylcholine should be performed. Initially avoiding opioids with induction is the main consideration for these patients. Once intubation has occurred, the baby will be out in just a few short minutes and normal maintenance can proceed. Sevoflurane and nitrous oxide are appropriate, as well as Teva with propofol. Due to the downregulation of adrenergic receptors present with pregnancy, one should expect to give a significant amount of phenylephrine or ephedrine to maintain blood pressure. Depending upon the severity of hemorrhage and coagulopathy, blood product administration is nearly inevitable. The drop in hemoglobin will warrant packed red cell administration, and the coagulopathy should be treated with platelets, FFP, and cryoprecipitate. The large amount of blood product administration could lead to hypocalcemia, which will be treated with calcium chloride. Another option to treat exsanguination will be antifibrinolytics, and according to the Woman trial, tranexamic acid is safe and effective to use in this population. Lastly, in order to facilitate hemostasis, uterotonics such as Pitocin, Methergin, and Hemabate will likely be administered to contract the uterus and halt bleeding. So now that we understand the pathophysiology, diagnosis, and anesthetic management of placental abruption, we'll go ahead and review a case study to tie it all together. So here we have a 40-year-old woman, gravidifor parafor, with a history of smoking about 20 cigarettes a day, and she presents complaining of severe abdominal pain and vaginal bleeding at about 17 weeks gestation. Hypotension and tachycardia were initially noted along with significant vaginal bleeding accompanied by blood clots, and her initial labs were a hemoglobin of 7.9, platelets of 82,000, a PT of 320, a PTT greater than 400, and a fibrinogen of 17. So she is definitely experiencing some DIC at this point. Upon ultrasound, a placental abruption was diagnosed. The hemorrhage associated with the abruption resulted in anemia, DIC, and hypovolemic shock. The patient was admitted for treatment, which included 10 units of PRBCs, 16 units of FFP, as well as surgical management. Prior to surgery, 2 hours later, the patient had progressively declined. Hemoglobin was 5, platelets 42,000, and her hemodynamic status had also declined with a blood pressure of 70/40 and a heart rate of 120. So once the patient was in the operating room and the incision was made, the uterine hemorrhage was extremely evident. It was noted that a hysterotomy and termination of the pregnancy was going to be the best course of action. A large hematoma, along with the uterus, fetus, and placenta, was all excised during the procedure. After the placenta was removed, an oxytocin infusion was initiated. They also administered an additional 20 units of FFP and 12 units of PRBCs during the procedure. After the procedure was finished, a total of over 2 liters of blood loss was measured. Post-operatively, the uterine bleeding finally decreased after about 24 hours. Her labs are here: hemoglobin of 9.9, platelet of 102, a PT of 10.4, and a fibrinogen of 296. So luckily the DIC was ameliorated and the treatment was halted, and the patient was discharged under her own power on post-operative day 6. So just some key points to go over. A placental abruption occurs in approximately 1% of pregnancies, and there are certain conditions that are associated with an increased risk of abruptions. These are going to be age, multiparity, hypertension, substance abuse, smoking, and trauma. While placental abruptions can be minor and still be associated with a vaginal delivery of healthy babies, they can also lead to significant blood loss and coagulopathy, as well as fetal demise. When anesthetizing a parturient with placental abruption, make sure to have blood products and antifibrinolytics, adrenergic agents, as well as uterotonics at the ready. Lastly, these patients are prone to having a difficult airway from a physical as well as physiologic standpoint. Proper positioning and use of videolaryngoscope, like a glide scope, is paramount to the successful management of these airways. Thank you very much.